introducing me. I will share my slides. Is it visible now?
No, we see your screen. Yes.
And now you see. Now you see the.
Perfect.
You see the whole. No, I don't see it anymore. Just a second. Now you see the screen.
Yes.
And the first slide.
Yes.
Perfect. Okay. Hello, everyone. I would like to give you an overview about treatment of pediatric PCD patients. I will try to transport the basics, and since there is not a lot of scientific studies telling us with good data how to do it, it's sort of also maybe the Berlin or the German agreement how we do it, but this problem is everywhere. So at first I would repeat what are the key problems in PCD and especially in the pediatric age group. We have an impaired mucociliary clearance, so the cleaning of the lower and upper airways. That means bronchi and trachea, and also the sinuses which develop and the nose doesn't work. So we have inflammation there and infection, and this causes the symptoms. If we look at especially in the pediatric group, the onset of symptoms, this is of course not 100% right, but just to give you an overview, we start at birth. 80% have this respiratory distress syndrome, which is many times misinterpreted, and people think it's a pneumonia, and we don't even know that children have PCD yet, but they do have this, many of them have this respiratory problems after birth. And then they have, in the first days already also the rhinitis, and then there's a chronic cough and the chronic bronchitis coming in the first months. And then a special problem for children, which gets less when they get older, is tympanic, there's an M missing, effusion, and also then hearing impairment, which can be in my clinic many times with the children, the leading problem in the preschool age group. So the basic principle of PCD treatment is the prevention of disease manifestation and the prevention of disease progression. So before I explain you this different therapies, it's about, you can say that a bit boring, there's not like a patient that has a big problem that comes to me. No, it's a patient that should have few problems or no problems. And we do treatments and education and programs to actually prevent the disease to manifest where there's a genetic predisposition, or that it doesn't progress. And this is very important to understand. So and also many children with PCD do diagnose and they don't report that they had 5 pneumonias and they were in the hospital. No, they had a lot of cough and they had this chronic bronchitis. No, that was kind of normal at some point, but that still destroys lung tissue and upper airway tissue over the years. So this is a basic principle. So also when we do therapy, this requires a monitoring of the PCD disease. And again, there's no cure for PCD so far. It's a lifelong, so the lifelong symptomatic therapy is necessary, and the therapy requires monitoring of the disease. So how we do it is that we do follow-up visits every 3 months that include physical examinations, sputum culture, lung function, also medical history. And then we do annual checkups, and these include, we usually do them even on the ward, but this is a German special thing because we cannot do things like MRI when they are outpatient patients. So we do physical examination, also the sputum cultures, lung function. We do blood testing, and this is blood count, allergy tests, screening for allergic aspergillosis, Pseudomonas antibodies. Very important hearing tests and ENT consultation yearly. And then chest imaging, and we prefer the MRI for children because it can be done semi-quantitative and also doesn't have radiation. And also very important is physiotherapy, also psychologic and social counseling, which is in our concept part of the yearly checkup. And of course it can be reached also in between, but everything gets reminded once a year. Regarding the lung function, the monitoring of the lung function is done by spirometry in children 5 years and older. And the typical value, the FEV1, measures the medium and large airways, and then like immersion technique, which is in some countries and some centers like ours totally normal, and others it's not used so far, is a multiple breath washout. That's called lung clearance index. It measures different things. It measures the ventilation inhomogeneity in the small airways, and can catch and can also be done in young children from the age of 2, or even with sedation in younger ones. So this is what I would recommend for monitoring in an ideal setting. This is just short scientific work that we've done, and could show that this is lung clearance index, which measures the ventilation inhomogeneity, is just as high in preschoolers with PCD as it is in preschoolers with CF. And this was before the CF children had the new drugs. So even in children already, in preschool children, the lung function is not normal, which is of course an argument for early diagnosis and treatment. We have seen this before today. Before I really go to the therapies, the vicious circle of pathophysiology of bronchiectasis. It's really the mixture of the impaired mucociliary clearance, which is inborn in our patients, leading to infection, structural damage, and also inflammation. And all this, if you take just one away, of those 4, it still goes on. So you have like a multi-factor influencing process of genesis of bronchiectasis, which also starts in the pediatric age. So what are the therapies for primary ciliary dyskinesia? I have a column model to make it easier to understand it. So the first column would be the mucolytic therapy, and I go into details. Then the physiotherapy and the autogenous drainage, of course, it is age depending, anti-inflammatory therapy, anti-infective therapy. There's a special area, the ear, nose, throat therapy in children especially, and very importantly, the physical exercise. So mucolytic inhalations, there's no data that back this up in TCD, but there is in CF, in cystic fibrosis. And many times we have to borrow the knowledge from cystic fibrosis because it's not there yet. So we recommend our patients daily wet inhalations with 4 milliliters of 6% hypertonic saline with an inhaler. And inhalative corticosteroids are not standard therapy for PCD, and also from my point of view, only indicated when allergic asthma is there as a comorbidity. And to give an outlook in the future, and I hope Felix will talk a little bit more about it because he was involved in the study. There is a study in adults promising that the inhibition of a certain ion channel in the airway can make for PCD patients the mucus more easier to get out and improves lung function. But this is as for the pediatric patients in the far future. We haven't done any studies yet. Then there is the sinus-anal flushing every day, which is also very important with those commercial things. You can flush depending on the size of the human 10 to 100 milliliters of saline, normotonic or hypertonic. Also very important. Then, of course, the physiotherapy and the autogenous drainage. Of course, and as a baby, it's difficult to do physiotherapy, but you can start very early to get them to used to it. And this also depends on the country where you are, if it's available. And then when you get older, the autogenous drainage, like learn techniques to get out the mucus from the lungs, and also physical exercise. And especially the coughing techniques and secretolysis is very important, like sufficient cough and seizing techniques for mucus clearance have to be taught by a physiotherapist, by someone who really knows how to teach this to people. And also aiding devices such as flutters, as shown here in the picture. And in contrast to cystic fibrosis, the mucus is already thinner, so it can be mobilized mechanically, which kind of shows the high importance of this mechanical removing of the mucus. And many children, when they get older, they learn not to cough because they feel how do you say that? They don't feel comfortable when they do it. And this is something that at least when they're in the safe environment has to be looked at, that patients clear their mucus because they can. And then there's the anti-inflammatory treatment. And there's at least one therapy that's evidence-based for children from the age of 6, but I would also recommend it for younger children when they have problems with with exacerbations. It's azithromycin maintenance therapy. Azithromycin is an antibiotic, a weak antibiotic, which has as a off-target effect, like a side effect, anti-inflammatory properties. So, so it has been shown that taking this therapy as a maintenance therapy reduces the pulmonary exacerbations, let's say the acute on chronic bronchitis, you could always call it like this. And at least from CF, there's also baby data showing that it's safe to have 10 milligram per kilo per body weight 3 times weekly. And this is like a general recommendations we give to our patients. And to steroids, which of course are known to be anti-inflammatory, again, inhaled, they are only indicated with comorbid allergic asthma. It can be useful in case of acute, very bad exacerbations to be as a like a few day anti-inflammatory therapy. And the topic nasal steroids can also be maintenance therapy in many cases, but they don't. You have to do the flushing first and then use it. And then here also, and there's something not in the far future, but in the near future, a new anti-inflammatory therapy. It's called cathepsin C inhibition. There's 2 companies actually developing. When you look here at the image, it's a drug that can block the liberation of inflammatory enzymes from the neutrophils, which are like cells, like immune cells, and it is already in the clinical trial in the phase 3. So that's the last phase before the marketing from 12 years and older. And we're very keen to see the results because it might become the new standard therapy for anti-inflammatory, even maybe on top of the azithromycin or instead of it. And maybe it can even prevent disease progression. And this data here just showing that it was very effective in adults in the phase 2 and for the, as I said, the big phase 3 trial where there's more than 1,700 patients in, and we're waiting for the results next year. And anti-infective treatment, it's first, it's important to understand that there's everyone is colonized with some bacteria. Like every patient with PCD has a chronic bronchitis with bacteria, and so we don't treat bacteria itself, but we treat pulmonary exacerbations. And for this we need sputum culture. We do like sputum surveillance. So we have cultures or throat swabs every 3 months, and then when the child is worse, we can treat right away without waiting for the result. And the standard would be a 14-day targeted therapy with amoxicillin clavonate. That's what we use the most because the most common germs are Staph aureus and Haemophilus in the pediatric age range. And for Pseudomonas aeruginosa, which is kind of a special germ, we've heard from Susanne about it. We try to eradicate it when there's a first detection. Have to treat differently when there's a chronic colonization and have an exacerbation. And but there's also the concept, even from CF, because there's not a lot of data with PCD, that we do suppression therapy when there's a chronic infection with Pseudomonas preferred with inhalative antibiotics. But I think we will hear more about this in the next talk for adults, because this is something that's really more like more an adult issue than a pediatric issue. And the ear, nose, throat area is really an area to have a special focus on. And many times ENT procedures are conducted before the PCD diagnosis is established. And hearing impairment due to tympanic effusion is very common in preschoolers with PCD, as I said. Important point is that here a grommet, that grommets should not be the first line treatment for this. And we recommend a low threshold for temporary hearing aids, because when the children get bigger, actually this problem due to the change in anatomy gets, the gravity helps us then, gets less, and it can also be then done without grommets. And sometimes we need local and systemic antibiotics, clearly when there's infections. Also the nasal flushings help. And then, as I said, the nasal topic corticosteroids. And also for nasal polyps surgery, when you have the diagnosis, it should not be first line treatment, because we don't change the problem. We rather, it then will come back if you don't change the maintenance therapy. So that's like, as I said, many times in the preschool age, the ENT area is the one that's the most obvious to cause problems. And last but not least, physical exercise is as important as all the other treatments, especially for like for the lungs. And children should just start sports as early as possible. And so it's really my recommendation, and that's what I tell all the patients when the children get older. Find something. If it's riding the bike, this is my little son here, or playing baseball, going jogging, whatever, swimming. And there's also no restrictions that any sport should not be done, and because of the disease, it's the other way around. Every sport should be done because of the disease. And so what is further important as preventive measures? It's of course vaccinations, overall the influenza, the flu shot, of course the air pollution in the environment and in where you live. Absolutely no cigarette smoke. That's self-explaining. In Germany, we have something like rehabilitation, that you can go with your family for like a month in a place on the ocean, where you get everyday physiotherapy and a lot of education. That's also very helpful. And as I said, the psychological and social counseling. So in summary, PCD therapy is all about prevention of disease manifestation and progression. This requires monitoring, mucus clearance, inflammation control, infection control as the most important things, and the sport. I forgot that here. And there are established therapies with few evidence, as I've presented to you, but new specific therapies are on the way and will reach also pediatric patients approximately in 3 to 10 years. And it was here that the one that's coming first would be the new anti-inflammatory, the catecholamine C inhibition. And then there's other therapies like the ENaC blockage or also RNA therapies that are on the way, but this will take a while until the patients will really see it. And finally, I would like to show you the big team in Charité in Berlin. We are like in the pediatric hospital, but we are also the place for the adult PCD patients. So we integrated it together with the CF center, which is very helpful because many things are equal that are needed. And I will be happy now to answer your questions.